I kind of grouped this. Mostly I will talk about new procedures, and then at the end some new medications. But within cardiology and heart work, most of the new things are really procedures. So I will focus about new tests and new procedures, and then we'll open it for questions. So first we'll talk about tests that don't require needles and catheters and things like that, and we call that non-invasive testing. So one of the things that has been out for a few years is the CT scan of the arteries of the heart, which basically is similar to any other CT scan, but these are more advanced machines, and they have higher resolution. Now in the past, CT scans was not high resolution enough to be able to see the arteries of the heart, because the arteries of the heart, as you know, they're much smaller than other arteries, and the heart is always moving. So it was kind of hard to capture the arteries with all that motion with every heartbeat. But the technology of CT scan has improved to the point where the resolution is much higher and the machine moves very fast, so it's able to capture the arteries of the heart after we give contrast or the IV dye. So as you see here, this is a picture of a CT scan. It shows you the artery of the heart looks nice and clean without any significant plaque buildup, whereas here in this picture, this is a picture from a CT scan, and it does show you that the artery here is extremely narrowed. And this was confirmed by a heart catheterization and showed the same thing. So this technology is very, very accurate in detecting heart disease, even without doing a heart catheterization. So this is the closest picture that you will get to a heart catheterization without basically putting a needle inside and going through the artery. So the advantages of this technology is that it does not require a catheterization. It's very quick to perform, and it's really accurate in terms of estimating the plaque buildup and blockages. But it does have some problems. It's still the same issue. There is radiation exposure from CT scan, which is every year is actually improving because they're able to do these kind of tests with less radiation. It still requires the IV dye, so if somebody is allergic to the IV dye, they still have to be, we have to be careful about that, and we have to prep them. And then if we do find a blockage, then a heart catheterization is needed because we're not able to treat these blockages with stents by CT scan. You will end up having a CT scan and then a heart catheterization, and that's why we have to carefully choose this technology. If I have a patient in the emergency room coming with symptoms of a heart attack, and I think they are really having a heart attack, I'm not going to do a CT scan on them. I will proceed directly with a heart catheterization because I'm thinking that there is going to be a blockage that needs to be treated. So there is no point of having them go through two different tests. Now, this technology is still restricted by insurance companies, so when we order it, we really get a lot of grief from the insurance companies about prior authorization and things like that. So if you come and see me and you ask about this, we can't promise you that you'll be able to have this test done, depending on what the insurance company says. And it's still not widely available. We do have the machines here at Alamance Regional, but we're not doing it routinely. We're doing it routinely at Moses Cone. So it is, the technology is available, although it's not widely available. We also have MRI of the heart, so which we call cardiac MRI, and this is really a neat technology, and it's really not for everyone. This is mostly for people who have a weak heart muscle, and we are trying to determine what's the cause of the weakness in the heart. Then most of the time we do an MRI of the heart muscle because it can tell us what kind of weakness in the heart they have. It's also very good when the heart is weak and we are trying to determine if the heart muscle is dead in that part or if it's still alive, because if it's still alive in some part and there's a blockage, then opening that blockage usually helps. But if the heart muscle is completely dead in that area, there is no point of trying to do open heart surgery or stent when the heart muscle in that area is dead. So the MRI is the best test to tell us if there is what we call viable heart, which is, heart cells that are still alive. There is a lot of you here probably had echocardiograms or ultrasound on the heart. And the most common kind of echocardiogram we do is what we call the two-dimensional echocardiogram, which it has 2 dimensions basically. But now we have 3 dimensionals, which you can see it in 3 dimensions. This is very good for looking at the valves of the heart and determining if surgery is needed, if the heart is narrowed, if the heart valve is narrowed, or what kind of, for people, for instance, who were born with some kind of congenital heart disease, this kind of test is extremely good. So we move now to, this is my field, interventional cardiology, which is, catheterizations and angioplasties and stents and things like that. And there is a lot of exciting new things in this field. How many people here had a heart catheterization before? So how did they do the heart catheterization? Did they have to go through the groin?
Yes.
Okay. Did you like that? So a lot of patients, when they go through a heart catheterization, if you ask them to go through a second heart catheterization, the first thing they remember is when somebody was mashing in their groin for an hour, which usually is 10 minutes, but it feels like an hour. And some people end up with bleeding in the groin. Some in the old days, they will have this sandbag sitting in there for a few hours. Thank God we're not doing that very often now. So the problem with heart catheterization has always been the complications that can happen from going through the femoral artery, which is in the groin. In the old days, when we did heart catheterizations, the catheters were large in size, and that was really the only option because the artery in the groin is a large size artery. So that was the only option because we needed an artery that will be able to fit our catheters that we use. And if we have a very big catheter and we put it in a small artery, obviously that does not work. So the technology has improved to the point where when we do heart catheterizations now, we really don't need a very large catheter. We can use a small size catheter. And because of that, we started thinking about, well, how about we do the heart catheterization through the radial artery, which is basically the artery when you feel your pulse here. So that's the radial artery. So we're doing that. So I started doing that here at Alamance Regional last year. And 85% of my patients, when they have heart catheterization, they have it through the radial artery. So you can say, well, what's the advantage of that? The advantage of that is that the bleeding complication is much less if we do it through the radial artery because the artery is right there. You can compress it with 2 fingers. You don't need any sandbag or anything like that. Then also at the end of the case, we take the catheter out and we put, this is a bracelet here. We put that bracelet on and basically you can walk after your heart catheterization. So you can stand up right after a heart catheterization. You don't need to be bed rest for 6 hours on your back or anything like that. And really what we have known from doing heart catheterization that the #1 complication or things that can happen during heart catheterization is related to bleeding complications. Because the femoral artery is very deep inside, so when we compress pressure on it after we take the catheter out, somebody can still bleed inside, and because the artery is deep, sometimes we really don't, there's no way for us to know on time. Sometimes they can bleed 2 pints or 3 pints of blood before we notice that there is swelling there. So, whereas in here, if you bleed, you're going to see it right away. It's right under the skin. So there's a big advantage for doing a heart catheterization through the radial artery. Now, not everyone is a candidate for this. Some people have a small radial artery. So most of the time, or all the time actually, we do test the circulation in the hand before we determine if somebody is going to have this done or not. And sometimes even when we try, there's about 5 or 10% chance of not able to go through this if there is a lot of spasm in the radial artery. So it's not for everyone, but the majority of patients are a candidate for this kind of procedure. So this is a patient right after a heart catheterization. He's wearing the bracelet and he's walking. This is immediate, basically. Now, the other thing that's extremely important is treating a special kind of a heart attack. There is what we call heart attacks that's due to a complete blockage in the artery or 100% blockage in the artery. These are the kind of sudden heart attacks that happen like that. You start having symptoms of a heart attack, and then when EMS comes or when you come to the emergency room, when we do an EKG, the EKG identifies this kind of a heart attack, which basically indicates that the artery is completely blocked. So when the artery is completely blocked, we're basically racing against the time, because the longer the artery stays closed, the more damage to your heart will get from that blockage, because during that time, that part of the heart is not getting any blood supply at all. So, so when we see this kind of a heart attack, the treatment, in the old days, we used to give these strong blood thinners to everyone, the clot busters, blood thinners, but that was associated with more complications of bleeding and things like that. So the treatment of choice over the last 10 years have been, if we identify this kind of a heart attack, is to do an emergent heart catheterization. So these are the situations where if we see this on the EKG and somebody is having these kind of symptoms, we take them to do a heart catheterization right away, whether it's at 1 in the morning, 2 in the morning, it doesn't matter. On weekdays, weekends, anytime they come, if we see this, the treatment of choice is to do a heart catheterization. And then, as you see here, basically this artery was blocked completely. Open the blockage with a balloon. There's a wire down there, there's a balloon, and then got a stent and establishing the blood flow. So this is now a normal blood flow in this artery where it was completely blocked in here. So this kind of treatment was at some point restricted to large hospitals and university hospitals and things like that. But the procedure of doing a heart catheterization and angioplasty became very safe over the last few years, that a lot of community hospitals are starting to do that. So we started doing this at Alamance Regional in 2008, and we're offering this. There's a big advantage when we do this here, because when we have a patient coming from Burlington through the emergency room and we see that, our average time from the time they hit the emergency room until we open the artery is only 36 minutes. So, and we keep track of that. We monitor that, and we know exactly what we're doing. So if somebody comes to our emergency room and they're having these kind of heart attacks, the average time for us to open that artery is only 36 minutes. We have much newer technology to help us, working on a patient with a heart attack. Very common things when we do a heart catheterization in somebody who is having a heart attack is we find that the artery is blocked with a large amount of blood clot inside the artery. And many times when we try to open that artery, this blood clot, we can send it away with the wire, but it goes downstream and it clogs the artery in the small branches. So we try to take these clots out, and we have special catheters to do that, like this. This is a blood clot that wasn't inside an artery. So we take something out like this. We clean the artery before we put a stent, so that the clot doesn't go downstream and causes more damage to that artery. Now, the stent technology is just phenomenal right now. The improvement in that technology is unbelievable. When stents came out more than 20 years ago, they were very, very rigid and hard. They were very thick, and we really had hard time advancing these stents inside the artery, because the artery is curved, and these stents were kind of frigid. So we kind of suffered with that, because some patients were not a candidate for the stent if the artery was very curved in itself or has a lot of calcium buildup. But the technology of the stents is improving every year. And now what we have is called third-generation drug-eluting stents. These are stents that are coated with medication inside to prevent scar buildup inside the stent. And these stents are extremely thin and flexible. And I really, over the last 5 years, I mean, I can see a huge difference when I do angioplasty and stent placement. It's just, my life is much easier because I'm able to deliver these stents to areas where I've never dreamed of being able to deliver stents in the past. The long-term results with these kinds of stents is extremely good in terms of preventing the blockage in the same area. And one area one concern we dealt with what we call the first generation drug-eluting stents. When these stents came out and we started coating them with medication from the inside to prevent scar tissue, one problem we had early on is that a lot of patients ended up having blood clots forming on the stent, and these clots were actually leading to a heart attack. And that's probably what in the news a few years ago you heard, well, stents are causing a heart attack. Well, it was causing a heart attack because of the clot buildup on the stent, which was a problem with the first generation drug-eluting stents. And these came out in 2002, 2003. We don't use them anymore. The newer kind of stents, they really don't have that kind of problem at all. So obviously, any kind of stent will require you to take a blood thinner because we want that stent to heal inside the artery completely before you stop the blood thinner. Otherwise, the body might think that this is something like a foreign object inside, and it will try to form a clot in it. So that's why we always give a blood thinner after a stent. Now, this is very exciting new technology, which is replacing heart valves without open heart surgery. And that's going to be huge. So the most common type of heart valve problem is the aortic valve, which is the valve that opens so that the blood will go out from the left ventricle to the rest of the body, and then it closes when the heart relaxes, so the blood does not go back to the heart. Very commonly, especially with age, we get calcium buildup on the valve, and the valve becomes rigid. So normally it opens like this with every heartbeat. When it's calcified, it starts narrowing like this, and in certain time, it might just open like this, like a pinhole. I mean, just letting some small amount of blood going out. And as you can imagine, the heart is trying to force the blood out through a very narrow hole. And that's not fun, because the heart after a while will get tired, and it will lead to congestive heart failure and weakness of the heart. So, and there's really no medication to treat that condition at all. If somebody has what we call aortic stenosis or aortic valve stenosis, the treatment has always been open heart surgery, opening the chest, take the valve out, put a new valve in. Now, many times, especially for people who are above 75 or 80 years old, they have a lot of other health issues, and they were not a candidate for surgery because we felt that if we make them go through open heart surgery, they wouldn't survive it, or if they do, they will end up with a lot of other potential complications and very long recovery. So that's how this there has been thinking about, well, is there a way to do that with catheters without having to do open heart surgery? And now it's possible. So this started about 5 years ago. It was research at that time, but right now it's FDA approved. So this technology is out there, and it's being done. Obviously, we don't do it at Alamance Regional because this is the kind of technology you have to have surgeons on standby. So it's done at Duke. We're starting at Cone. Later this month, we will start our first case. So this is very exciting technology. And the way it's done, as you can see here, so this is the valve right here. And then we open that valve with a balloon and then place a stent in that area, which is, it's a valve, a special kind of a valve. And it's done through the groin area, through the femoral artery. So this will explain to you how this is done. So this shows you the heart beating. And this is the valve I told you about. Look how narrow it is. It's supposed to be wide open, but it's only opening a little bit to let the blood go out. And the valve replacement is done through the femoral artery in the groin. So we advance a wire, and this wire will go inside the aorta, come back to the heart, and we let the wire go through the valve, which is right there. And then we're inserting a balloon, a special large size balloon, so that we kind of make the valve open all the way. So we inflate the balloon and we make the heart stop temporarily for a few seconds because we don't want the heartbeat to send the balloon up. And then after the valve is open, now we're going with a special kind of a large catheter. And then inside that there is the valve. So this is the new valve right there. Then we advance it. And this has to be done very carefully with the ultrasound imaging and make sure that it's placed in the right place. Once it's there, we put the valve there. And then the valve is opening and closing, and then take the wire out. And then they will show you how the valve looks now, this new valve is. So look at the opening of this valve. It's opening all the way. So this is what we call TAVR, and that's the valve replacement. So for congestive heart failure, basically is when the heart is weak. So when there's weakness in the heart and the heart is not working efficiently enough to send the blood out, and that leads to fluid buildup in the lungs and legs and things like that. So there are procedures that really they've been out there for a while, but I just wanted to mention them so that you will know what kind of options you have if you have heart failure. So there is the intracardiac defibrillator for people with very weak heart muscle. If their ejection fraction is really the number that we give to anyone with heart failure to determine how weak or strong the heart muscle is. So each one of us has a number if we do an ultrasound or stress test. So the normal ejection fraction is between 55 to 65%. So the defibrillator is recommended for people who their ejection fraction is less than 35%, because we know if the heart function is that weak, then the heart is at risk of what we call arrhythmia, or the heart getting out of rhythm, leading to dangerous heartbeats that can make the heart stop suddenly. And the only way to do that is to shock the heart. So that's why the defibrillator is there, to give the heart a little shock if the heart gets out of rhythm. With the defibrillator, there's also a special kind of a pacemaker where it goes to the left side of the heart. It will help the heart be in sync together. So for people who have a very weak heart and they have a special type of EKG, they might be a candidate for this kind of pacemaker. It's called biventricular pacemaker. The defibrillator will not make you feel any better. So you'll not feel that your shortness of breath is better after a defibrillator. The defibrillator is there only to detect the dangerous heartbeats and shock the heart if needed. So a lot of people think, oh, well, if I'm going to get a defibrillator, I'm going to feel better. No, it's just there as a safety issue. So it's like, if you have a fire extinguisher in your kitchen, it's not going to make your food taste any better, right? But if you get a fire in the house, you'll be glad you had it. So the same way I try to explain for a defibrillator is there as a safety. And some people, I usually discuss this with my patients to make them decide, because some people are completely against something like this. They say, if my time is up, just let me go, So it depends on the patient's preference and the age and other problems that they have. The special kind of a pacemaker, if somebody is a candidate for it, it will potentially improve the heart function because it will help the heart get in sync together, the both sides, the right side and the left side. If we can't, there are a lot of medications for heart failure that we can improve the heart function with angioplasty, stent, open heart surgery, medications, but sometimes the damage is so extensive that we can't reverse it. And in that situation, a heart transplant is a last resort. The problem with a heart transplant is that there is really limited donors for a heart. So we have a lot of patients who have congestive heart failure who need some kind of extensive treatment, such as a heart transplant, but we don't have enough hearts to give to everyone. So the hearts are usually limited to certain type of patients that are usually younger than others. They're otherwise healthy. They don't have other medical issues. So if somebody is not a candidate for a heart transplant, or they've been waiting for a heart transplant for a long time, then they might be a candidate for what we call a left ventricular assist device. So Vice President Cheney, he had something like this before he went on to have a heart transplant. Sometimes they go through this to give them more time until a heart becomes available. So this is a mechanical, you can say it's a mechanical pump basically that goes under, it goes in the stomach area under the skin, and then it has wire coming out. This is the control system, and the battery is here, and the pump is here. You just have to make sure you don't run out of battery. Then there is the ablation procedures. You probably heard about that. If somebody has problems with the heart rhythm, with the electricity, such as atrial fibrillation, which is a very common condition when the heart is completely out of the rhythm in the upper chambers, then there are some kind of procedures. We go in and do what we call ablation. We use radiation to burn some parts of the heart where it's causing trouble with the electricity. So this is a very good procedure for somebody who's having arrhythmia problems in spite of medications. So we finished about, just quickly here, just the slides about what's new in terms of medications. There are blood thinners for AFib. Most of you heard about, they know about warfarin and Coumadin, and a lot of people like that medication, and a lot of you hate it. So there are alternatives to these medications, and we are using it very, very frequently. The problems with warfarin has been that you need a different dose for each patient. So many times you have to start the patient on warfarin or Coumadin and then bring them back in a few days to check it, and you keep checking it until you get it in the range that you want. And that process might not be always easy. And then the warfarin can interact with a lot of other medications, and the food you eat, especially the vegetables, green leafy vegetables. So there are problems with warfarin. I'm very happy that now we have alternatives. We have 3 medications that are approved for this kind of indication to prevent stroke in patients with atrial fibrillation. There are blood thinners for patients after a stent. So for many years we had Plavix for a long time, and that was the only thing. But we have known that Plavix in about 25% of people doesn't really work very well. And we didn't have any alternatives for many years. Now we have 2 new medications that we can use in these kind of patients. And the cholesterol guidelines came out late last year, and statins, the cholesterol medications, are safe. I know a lot of people they doubt these medications, but we had them for a long time, and they are extremely good medications to prevent future heart attack and stroke.